Hello, everyone. We are pleased to welcome you to the Data Collection webinar series, which is organized by the Data Collection Unit at UNICEF headquarters. I am the chief of the unit, Attila Hanjoğlu, in UNICEF headquarters. This series covers topics that have recently gained relevance or importance, and where there is ongoing work on how best to collect data. And today's webinar is entitled What Drives Vaccine Uptake? Gathering and Using Data to Address Behavioral and Social Drivers of Vaccination. Before we start, some housekeeping rules. We have scheduled about an hour and 30 minutes today, including Q&A. Please, throughout the webinar, remain muted. Kindly write your questions in the chat box, and we will try and group your questions and direct them to the presenters during the Q&A segment. The webinar is being recorded and will be available on our SharePoint site, together with the past webinars. We'll also post recordings onto the Mix YouTube channel, and so are publicly available as well. You can find the links to both of these in the email that you received. As I mentioned earlier, today's webinar is entitled What Drives Vaccine Uptake? Gathering and Using Data to Address Behavioral and Social Drivers of Vaccination. And we are happy to have with us three presenters. Lisa Menning, who is the team lead, Demand and Behavioral Sciences, Essential Program on Immunization, Department of Immunization, Vaccines and Biologicals at WHO headquarters. We have Noel Brewer, Gillings Distinguished Professor in Public Health, Professor of Health Behavior at University of North Carolina here in the USA, and Amaya Gillespie, who is a Senior Behavioral Scientist at UNICEF's Manaro, Middle East and North Africa Regional Office. So Lisa, the floor is all yours to start the webinar.
Thank you very much, Attila, and thank you to UNICEF for the opportunity to join you for this webinar today, and also for the general excellent collaboration in this area of work. So in our webinar today, I'm introducing our agenda for the presentations to come. So I will provide a brief overview on what drives vaccine uptake and the tools that we have developed to understand behavioural and social drivers of vaccination. We'll then go to Noel to take us through the work that we carried out to develop the tools and to establish their validity and reliability. And then we'll go over to Amaya Gillespie with UNICEF to take us through some examples of use of these tools to gather and use data. And we'll then come back for some questions and discussions before we finish the session. So just to begin with, to offer some context for information on these tools, to start with a quick look at the various data streams that immunisation programs routinely use for planning. And we can see that programs normally use data on disease surveillance, on vaccine coverage, on individuals that were immunised or missed, and other program data on supply and wastage and other topics. And the routine gathering and use of this data offers programs an understanding of where and a little bit about who is being vaccinated, but rarely about why. And so to support programs to truly design tailored and targeted strategies and solutions to achieve high uptake, we really need to know more about our target populations, and to be at the same time gathering and using data on drivers of vaccine uptake and use that data together with these other sources for a more complete understanding of the different trends and situation that can guide planning. So with the objective of developing globally standardized tools that could support gathering and use of behavioural data, WHO in 2018 established a working group on this topic, and with global partners and experts from around the world, over a 3-year period, we had a structured and stepwise process for developing tools and guidance on these drivers of vaccination. And one of the key outputs of this effort was the framework that you can see here. And this illustrates the behavioural and social drivers of a framework and the 4 domains that are measured through this effort. And this framework was developed and refined iteratively with our working group. And it shows the beliefs and experiences on vaccination that can achieve and affect uptake. So these 4 drivers can be grouped in 4 domains: people's thinking and feeling, and this is where we situate confidence in relation to vaccination. There's social processes and social influences such as norms. This includes a recommendation from a health worker, plus also gender or equity related barriers. Thirdly, there are motivations. This is individuals' willingness or intention towards vaccination or hesitancy towards getting vaccinated. And then practical issues, which includes the experiences of trying to get vaccinated, such as access, availability, and affordability, the cost of transport, for example. And this is an area that's not always systematically assessed, but really important new part of the tools that we've developed. So this framework can be used to guide our understanding and measurement of these important drivers and have been used to structure the subsequent tools that we have developed. So to go more into these tools, we have a set of tools for understanding childhood vaccination, and that includes a survey for parents of children under 5, plus also qualitative tools that are targeted towards different stakeholder groups such as parents, health workers, and community stakeholders. And we also have a corresponding set of tools for COVID vaccination that includes surveys specifically for adults and health workers. And these were the populations that were prioritised for COVID vaccination at the time of development of these tools. And we also have a similar qualitative tools. And these tools come with practical guidance to support the process of planning to gather this data with methodological guidance, etc., plus also further recommendations about how to analyse and use this data as part of program planning. So just to take a quick look at the topics that are measured through these tools. As you can see, these topics are gathered across the 4 domains that I described earlier, and each of the different boxes or cells on this chart corresponds to a different item or question in our survey. You can also see that we have some demographic items included here. And so what this means is that the topic or construct of confidence in vaccine benefits, for example, that corresponds to a question in our main survey. And the items here in red also indicate that these are a priority question, which correspond to a priority indicator. So if a program only has an opportunity to include a small number of questions in a data collection activity or an assessment, what have you, these are the 5 questions corresponding to the indicators that we would recommend using most regularly. And this can also contribute to routine monitoring and tracking across these priority questions or priority indicators. Just to take a closer look at these priority indicators, for example, this illustrates the simplicity and language that's used in the questions and the response options for each of our priority indicator questions. On the right-hand side here, you can also see the wording of the corresponding indicator. But as an example, again, looking at the top row here, the item related to confidence in benefits, the question is, how important do you think vaccines are for your child's health? Would you say not at all important, a little important, moderately, or very important? And you can see the corresponding indicator. And this shows to illustrate the ways in which we really focused on every single word almost in these questions to make it as simple and readable and understandable as possible for both the question and the response options. And Noel, in a moment, will talk through more of the work that we did to design these questions and also to select these priority indicators. Just a further word as well about our qualitative tools. This slide here illustrates the corresponding qualitative questions in our interview guides that can be used, and again, relating back to the quantitative or survey item, this illustrates the array of questions related to ease of getting vaccination services. And we designed this also in such a way that the survey and the qualitative tools or the interview guides also are structured corresponding to the 4 domains, and that's intended to facilitate analysis between the various tools. So here, being able to see the qualitative items, these are classic open-ended questions with probes to elaborate and establish a deeper and richer understanding on these different questions. I'll take a moment to just comment on hesitancy. And hesitancy is a topic where there's been a lot of attention in recent years. And in the work that we did with our working group, we paid a lot of attention to this and had specific discussions to better define hesitancy and also to then determine how it is measured. And we therefore updated the definition of this term through our effort. And this is an update compared to previous WHO work in this space. And we've defined hesitancy as a motivational state of being conflicted about or opposed to getting vaccinated, including these intentions or willingness. So it's situated in this motivation domain, and it's absolutely important that our having a good definition and description of this therefore informs an accurate measurement and ability to act on this in a well-informed manner. Also noting that hesitancy, as we've defined it, is separate to confidence, and we've reiterated this definition of confidence that as a belief that vaccines are safe, effective, and part of a trustworthy medical system. So why do we need to be measuring best? I think a lot of this would be quite self-explanatory, but to touch on a few key reasons here. Firstly, just being able to understand all of the reasons or causes for low vaccine uptake, and to use that data to guide planning, evaluation, policy making, and all of the necessary discussions around implementation and the selection and tailoring and targeting of specific interventions that act on the various drivers or barriers that are identified. And with that, we're able to better allocate resources, to use resources more effectively, and to have more transparent and accountable discussions and planning processes around these corresponding strategies, to use that to guide training, capacity building, stakeholder engagement, advocacy, all sorts of other peripheral activities that are really important to ensuring that programs act on the relevant barriers to uptake. And then also with a focus on the priority indicators that we've identified, those can be used for more routine tracking and monitoring, and consistent and comparable measurement, and that is between different locations or settings and over time. And whilst these measures can be used locally for such tracking and monitoring and evaluation purposes, the same measures against these indicators can be used at a regional or global level as well, for example, for reporting to the Immunization Agenda 2030, the M&E framework that's part of that strategy, or for Gavi reporting as well. So there are many ways in which these indicators in particular can be used. And so it's not just about gathering and using this data to have a better understanding, a better diagnosis of these reasons for low uptake. It's also about using this data for routine planning, implementation, and evaluation. So as part of the work that we carried out with our working group, in 2021, we carried out a scoping review to identify effective interventions that are shown to increase vaccination. And through the various review of that evidence and discussions with our working group, we took a closer look at the interventions here and identified ways in which each of these interventions can correspond to different domains or drivers or barriers where a problem is identified. And this can then support programs to move towards identifying interventions that will act on the barriers or drivers that are identified. It's also important to note this was based on global evidence, and a lot of these barriers and effective interventions will be context specific or even vaccine specific. It's also important to note that multi-component interventions, or a mix of many interventions, will be more effective than a single intervention. So it's possible to use a combination of these that also emphasises the importance of strong monitoring and evaluation and use of comparable measures as we go. So the outputs of our working group was presented to WHO's Strategic Advisory Group of Experts in October 2021, and WHO, as a basis of those deliberations with SAGE, published a position paper on this topic. And this position paper summarises all of the data and evidence that led to the finalisation of our tools and guidance on behavioural and social drivers, and has a summary of our findings on the scoping review of the interventions to increase uptake. And it includes a series of recommendations to programs and to partners about the systematic use of these tools and resulting data for program planning and implementation. And lastly, it lists a few future research directions. And this position paper is a key reference to guide the systematic use of these tools, and recommendations include ways in which the priority indicators, for example, can be embedded within routine program data collection activities or ad hoc surveys or assessments for this to establish an ecosystem of routine, regular collection of this data. So recommend you take a look at the position paper that's linked here. And based on that, some recommendations to countries and to programs in particular. At a high level, just a summary of these recommendations that can guide overall planning to use these tools and related data. So firstly, as a starting point, just to think about opportunities within existing data collection mechanisms in countries to integrate the questions that correspond to our priority indicators. So that would be a starting point. And then to look across other types of national planning, data collection activities and implementation activities, and to think about where the possibilities are to include surveys or other assessments, and that could even be qualitative assessments, qualitative data gathering, to really have a richer understanding of these drivers for specific subnational settings. And this data can be used by the NITAG, the National Immunization Technical Advisory Group, and it can also be used in other types of cross-partner, multi-partner coordination and planning discussions as well. Of course, this needs to be funded, so asks for funding to carry out these activities can be included in Gavi funding requests or even in funding requests to other partners. And with that, technical assistance can also be requested from Gavi, from partners, from UNICEF, WHO, and others. to ensure there's input into methods and sampling and other technical aspects of this data collection activity, any capacity building that can also go with that, and to identify other local partners that may have a specific specialised expertise that can contribute to this data collection work as well. And just a note before I finish is on how we're supporting the use of these tools with other partners and collaborators in this space. And it's really, we're taking a focus on building on the types of different data collection and monitoring and evaluation activities for immunisation programs that's already taking place. So working through these existing channels to promote awareness of these tools and really make sure that all of the necessary stakeholders and program implementers and decision makers are aware of these tools, the related guidance and program recommendations and policy recommendations. Also making available the necessary technical assistance for gathering and use of the data, and added tools like digital tools, the ODK, open data collection scripts and trainings and so on. Also facilitating use of the data and different kinds of dissemination and planning workshops that can go together with these tools, and other types of activities where we just continually listening and learning, looking at the data, looking at how the tools are being used, and using that as a basis to inform future work in this space. And this is an ongoing effort, and there will be a future work underway to really share and disseminate the overall findings that we're seeing in this space as well. And the WHO UNICEF joint reporting form that we use on an annual basis for data collection will play a key role there. So here's a slide just to show a slide to show the summary of the tools and guidance that's available. I've also included here the cover image of a guide here on human-centered design for tailoring programs, which is a participatory process that can also go together with the tools themselves. And this is the link of where to access the tools and guidance that I've described. So now I will hand over to Noel Brewer to take us into more detail on the development process for these tools, and in particular more detail on how we establish the validity and reliability of our tools. Thank you very much, Noel. Noel, you're on mute. Thank you.
All right, so great. Next slide, please. Who's moving the slides? Oh, there we go. Okay, great. All right, so I'll start by talking about the tool development phase, and maybe we can just move through some of the clicks here. I'm not sure. It's a little hard to do this remotely. All right, so we had a phase development process where we were first developed the tools through a process of literature reviews and consultation. Then we moved on to field testing, and then we did the psychometric evaluation. That's the part in blue, and then we finalized the tools and guides in purple. So in this yellow phase, that first phase, there was a literature review of looking through all of the existing literature to identify specific constructs we wanted to consider. We developed our qualitative interview questions as well as survey items, and then we iteratively reduced the number of survey items, developed demographic items as well as survey instructions. And all of that sounds like a little bit, but was really quite a lot. We also involved key key informants from globally, from low and middle and also high income countries. And then we also consulted with IVARAC. In the field testing phase, we considered various languages in various different countries. We translated and back translated all materials in and out of the major world languages. We developed the necessary study protocols and scripts, and then we translated, well, as I mentioned, translated all these materials. For the surveys, we did something called cognitive interviewing, where we asked users what they make of these items and what did it mean in their own language. We then developed these analysis plans that we tidied things up and did a bunch of revisions to things. For the qualitative tools, we also developed these draft qualitative interview guides so that people would actually have something concrete to use, and then interviewer debrief forms and analysis framework. This is a place where we involve the regional and country offices for WHO, as well as EPI program managers and implementers to gather feedback. Then that moved us on from the field testing, which is shown in green, to the blue, which is the psychometric validation and indicator selection. We developed this validation study protocol. The goal here is to establish that these survey items have the kind of characteristics you'd want in a quantitative research tool. Again, back to this, the translations for these specific items and back translations and survey analysis and so on. We then got the feedback from a working group to identify which items to prioritize, which ones to not include, and then which ones maybe are marginal to include as optional. And then we identified from all of those what the indicators would be. That is to say, once you gather these data, what would be the output of this specific survey item. And all the way through here, we also created this end user guidebook, and then we gathered feedback from folks on that. So then this next slide, please. So the evolution of survey items per step here is we started off through this literature review by identifying 259 possible items for the childhood vaccination survey. We took through expert review, narrowed that down to 30 items. We did our cognitive interviews that I mentioned before to establish what meaning people brought to the items. We know what they mean, but what do people actually take them to mean, which is the only thing that really matters. So, and through that, we identified 20 items to move forward into validation. And then through that, that validation, we then identified 5 of those as core items. All right, so let's move on to the next. Oh, I'm sorry. I should also mention that we focused on items that had specific characteristics. We wanted them to be proximal influences to vaccination that were measurable in individuals, that were specific to vaccination, and potentially changeable by immunization programs. So distal influences like literacy, education, the political context, and virality are covered in our in-depth interviews, the qualitative interview guides, as well as survey demographic items, but they're not necessarily covered in these core items themselves. Keep going. Next slide. All right, so we had data collection in 6 countries: Angola, the DRC, Ethiopia, India, Nigeria, and Pakistan. We have survey data from 1,819 parents or caretakers for young children. The analyses focused on 3 broad categories. One is overlap in information. So we did something called exploratory factor analysis and then confirmatory factor analysis to see whether there were items that were overlapping and thus could be removed. We wanted to have each item, the space in these surveys is relatively precious, and so we wanted to have each item be doing a lot of work and not be having a lot of items doing the same work. And we examined something called information curves for the scales to select the most informative items, and that is more or less the same thing that I just described. We looked at the second thing we looked at was stability. We examined the item stability across country, education, and respondent gender through something called differential item functioning via item response theory, as well as differential predictive ability. Do the items, are they as predictive of behavior across the different countries? And then finally, we examined whether these items were predictive of vaccination, which is exactly what it sounds like, is that we examined what was most predictive of uptake of all recommended vaccines for children this age. Next slide. Okay, so this is a lot to look at, and I apologize for that, but I'm just going to take the first row here to give you an idea, and I have to actually lean forward and squint a bit. All right, so if we take the first column, this row numbered 1 says vaccines are important. So that's the general topic of the item. It's a confidence item. And the next column where it says information, that says A, and it's a relatively dark green. So the dark green shows that it has a clear and strong loading and offering a lot of new information above and beyond other items on that factor. In this case, factor A, we've arbitrarily given it the letter A. So that's a good item. We want to keep that. Stability is also medium colored green. It's fairly stable, not as stable as some other items, but still pretty stable across countries and people. And then predicts uptake 0.27 is the correlation, the point by serial correlation between this survey item and vaccine uptake. So this in the gray column, you'll see it's in the survey. So the star means that it's a core item and it's one that we prioritize. And then the final column is a note on why we removed an item. In this case, there's no note because we kept it. And I'm going to go down to say the final row of the table, row 20. Heard anything about vaccines? It loaded on factor D, but it had terrible loading and didn't really give much new information at all compared to, say, item 18, which gave much more information. Then you move on to stability for that final row. Pretty stable, fine. It's not very predictive of uptake, 0.06. And then we did not include it in the survey. And then under the notes, we indicated low quality. So next slide, please. All right, so that was for childhood vaccination, and here we have the COVID-19 vaccination survey, and now these numbers, it's all a little jumbled, and I apologize, it's not exactly in the same order as you saw before, but the numbers the same. The numbers are the same. So let's take a look here at the second row, which is vaccines are important. Now this is very dark green, so it shows great. It's all, so this is loading on factor A, which is the same as the other factor A, more or less. The dark green is basically shows it has a good amount of information. It's fairly stable. It's pretty predictive of intentions because this is a time we did the survey when the vaccines were not as available. This was early on. 0.62 is really quite high, and then it's again a core item in the main survey. Next slide. One thing I didn't really point out is that we have core items, we have general items for main items. We also have optional items, and these items included things that either didn't have good psychometrics or were pretty overlapping or had other challenges to them. But there were several times where we just knew people would want them. And for example, trust in health workers, the role of religious folks, religious leaders in the community. We knew that in some countries, those would be very important constructs to look at. And so we included those survey items that we'd already done all this validation work on as optional. All right, so the final step here is this purple box here is the finalization of all the tools and guidance. So we now have tools for childhood vaccination, that's ages 0 through 4, and then we have tools for COVID-19 vaccination for adults and for health workers. We've also developed a guidance for data collection and use, and you saw a picture of that earlier. So our principles for the use of these BESD questions, there's a note that someone said that the slides are not moving. I don't know what to do. Maybe someone can help them with that technical issue. They're moving on my end, and I'm not touching them, so at least there's 2 people for whom they're moving. All right, so we have these globally field tested and validated tools, and the tools are focused on what is measurable, changeable, stable, and predictive. So these standardized survey and indicator questions are establish comparable data for looking across countries and within countries, and also looking at trends over time. There are standardized response options to the questions, either 4 options or a simple yes, no. We do not use the not sure response option, and it encourages people to not respond and gathers fewer data. No is placed first to avoid social desirability bias when answering questions, and the response options are designed for ease of analysis and use for data implementation. I will say that getting these response options right was a lot of work. The initial plans that we had for fairly simple ones didn't work across several different languages. They just didn't make any sense. So this current approach balances a lot of these different needs. So our goal was to maintain standardized use of questions, indicators, and response options across countries, and to add context-specific items where needed. All right, I'll turn things now over to Amaya.
Thank you very much, Noel, and also to Lisa. So I think my slides will be coming up. Yep, there they are. So I'm going to talk about how we've used this approach, and I'm mainly using examples from the experience of COVID-19. in the Middle East and North Africa region. And also that overlaps with the Eastern Mediterranean region of WHO. So I'm talking about work that was done jointly with UNICEF and WHO. So if you can go to the next slide, please. So the study that we did, we simultaneously studied the 23 countries of that combined region of WHO and UNICEF, Eastern Mediterranean, Middle East and North Africa. It was mobile phone based or CATI system, and we did it as a time series. We did it at 3 points in time. And we also started quite early in the COVID experience. So the first point in time was June 2021, when of course we did not have vaccines. And then the second was November 2021, and then June 2022. The reason that we did this, and I mention this because when you look back now, we say, oh, you know, that tells us stuff we already know. Actually, at the time that we started out, and as Lisa and Noel have outlined, you know, we were only just developing these standardized questions. There were none. So there was really very little behavioural data, or it was uneven across, you know, some countries had some, others had none. So it was really quite important for us. And also this provided us with a randomized denominator, if you like, a sample size of about 14,000, which meant that we could also have a comparator, if you like, for other types of data to know, for example, as social media data, how that really matched up with this randomized data. Next slide. So I'll just skip past this model, but just to say that we also framed our questions using this model as a guide. But actually, this model, the real beauty of this model is that it is so simple, this idea of thinking, feeling. There's a couple of constructs in there, social processes, etc. But you also need to think about some of the many other behavioural theories, okay, not just frameworks or models, but actual behavioural theories that can also inform each of these coloured boxes. So, for example, perceived risk in the yellow box, that comes from the health belief model. So for public health people out there, other behavioural scientists, etc., you might be familiar with some of these other theoretical models. We scanned across a whole range of models and also benefited from other people's work in this regard to pull out additional constructs, but very much overlapping with and guided by this really nice, simple model. So next. So to go into the key findings, so I'm going to cover the data as well as I'm going to actually talk to some of our learning at the same time. So the first thing is when we looked at our data, one of the things that became very clear very quickly is, you know, we have this huge population in each country and looking across the region. Once we find out this information about people, what they're thinking, feeling, doing, where do we focus? So next slide. When we looked at our data, and this very much relates to this idea of vaccine acceptance or hesitancy, this is data from the first data point in June, July 2021, before we had vaccines available in the region. And we were asking people whether they intended to be vaccinated. At that time, there was only a small number of countries. It was basically our high-income countries that had access to vaccines. Most of the rest of the region did not have good access. But when we asked this question, so we found in our region that about 20% on average had already been vaccinated. We found that 60% of the region were intending to be vaccinated, and only 5% were undecided. And for those, on average, unintending was about 15%. Those who were, you know, not intending to be vaccinated was about 15%. Now, at the time, we were talking a lot about about people resisting vaccines, people having negative views, being against vaccines, and all sorts of the problems with that resistance, even anti-vaxxers. But when you look at this slide, the dark, well, all of the green actually is suggesting a positive view, an openness to vaccination. So this actually changed the way that we framed our programming to now be talking about increasing vaccine acceptance rather than talking so much about hesitancy, which of course is a framing or a reframing in behavioural science terms, but it made a very big difference to the way that we program. The other thing that's, and I'll speak to a bit of that. The other thing that's affirming about this data was that when you look at the yellow, for us, the average was about 5% across the region who are undecided. This is a tiny percentage, and it does reinforce this notion or principle, if you like, that we talk about in behavioural science, that people tend to make up their minds in a kind of black and white way, a yes-no kind of dichotomous way, and they make it up quite early, and that they tend to seek information that supports that stance. And this data supports that idea. Very few people were still feeling undecided, like really not knowing. And over time, we did actually see the number of people saying they are not intending or refusing. We did see that reduce on average. We saw the undecided group reduce slightly, but in some countries it became absolutely negligible. And really only in a couple of countries we had like significant resistance, and the reasons for that also were very contextual in our region. So next slide. So when we look at, if we look at that data a different way, and you see on the red end of that, you see the 15% refusing, and on the blue end, you see the 20% of people who are accepting. And in the middle, you see really 65%. If we add the undecided, okay, if we think of them as possibly positive, and the intending are 60%, this 65% is quite a majority, which we referred to as the movable middle. And that's really was the focus of most of our work. We're not exactly ignoring the ends, particularly when you look at the blue end, people who had already been vaccinated once in this case. As the boosters came in, those people became more interesting to us in a behavioural sense because we wanted them to now repeat the behaviour. It's not just a one-off behaviour. Whereas at the red end, those who are refusing, what we found from looking deeper at the data, and I think it's now fairly common knowledge, that those people, for many of those people, it was more about identity, and that they were actually feeling negative about a whole range of things, particularly related to authority, to government, etc. And in that sense, it wasn't only about vaccination for many of those people. So the key thing, of course, if you just click again, was trust. And that, of course, became a very, very important from the start, was a very, very important element of what we were trying to do. So go to the next slide and just click again. So before the study, anyone who was not vaccinated, we were really sort of labeling as being against vaccination. But after we had this first data point, we were talking about people being not yet vaccinated or open to vaccination, but just there were things that we need to work out, barriers we needed to remove or overcome in order to change that. Next. And just the shift was from hesitancy, talking about hesitancy to acceptance. Next. So the second area that I wanted to sort of explore a little bit further in terms of this data, and this does get a little complex quickly, and like Noel, I will apologise in advance. If you just click to the next one, I want to talk a bit about what is behavioural data, behavioural analysis versus descriptive analysis. So very often when we do a survey, we will look at each of these constructs on the left, like the questions we ask are, do you think that vaccines are effective for yourself? The next one is, do you think if you get vaccinated, it will protect the community? It's protective for the community. How much do you trust local health workers, etc.? When we look at them one by one, it gives you a description, right? We call that descriptive analysis. And it's useful, it's helpful. In this case, we're looking at regional averages. Now, as a regional average, yes, it helps us if we were looking at other regional averages, but it's not really specific enough for us to program. What tends to happen when we look at data like this in a descriptive way is that we tend to then design a single response for as if this is a single person or a single population, that everyone thinks like the average. And of course, that's not the case. And this is one of the stumbling blocks that we've had in having a tailored approach to COVID, but also to a whole range of other things, is that we have this tendency to design a single response when actually we know that we should be designing multiple responses for the different people within this group. So if you click to the next slide. So what we did, a behavioural analysis, we actually looked at what is the important indicator that we're interested in. And in this case, it was kind of vaccination intention. And on the left there, you see those 4 categories of, at the top, the one circled is the people who are not intending to be vaccinated. The second line is that's that small group who are undecided. The next is those who are actually intending to be vaccinated, but they're not yet vaccinated. And the bottom row are those who've been vaccinated already, at least one dose. Now, if you look at a single construct now, or it's not a construct, actually, it's a question related to a construct. How much do you believe that this new COVID vaccine at the time would be effective for you, if you're able to get it right now? So when you look at it by the different people, if you like, or subpopulations, segmenting that average number into whether you've been vaccinated or not, or how you're feeling about it, you start to be able to compare and you see who these different populations are. And as you would predict now, now that we've all been through COVID for several years, you see that people who are not intended to be vaccinated feel that it's less effective than those who are more positive towards vaccination. But it's interesting to see that actually there might not be that much difference between some categories. And in this case, you see everyone else actually feels like it's pretty effective. So then for your programming, you might think about, well, what are the other things I could program for, rather than just telling people about the different vaccines and how effective they are? What are the other things that actually might shift these people along, closer to being vaccinated? Next slide. So if we look at, we did the same thing for how safe, and I won't go through each of these in detail, but it's the same idea. You can see that people who are not yet vaccinated or people who are undecided on this one are more concerned about safety. They're less likely to think that it's safe than the other 2 categories. So here's something like, let's look more deeply. What does this mean, safety? What is it that they're really bothered about? Next slide. So you start to build up this picture of looking at these different items related to the key constructs and how they describe these different subgroups of the population in relation to their intention to be vaccinated. This one's about side effects, highly correlated to safety, and you start to see something interesting here. And what we deduced from this slide is that actually everybody believes that there are side effects. Everybody knows there are side effects. Everyone believes that there are side effects, but it need not stop you from being vaccinated, because some of these people are already vaccinated. Some are intending to, not yet. But everyone knows about the side effects. How concerned they are, though, is what makes the difference between these different categories, which we found by looking more deeply in the data. So this is useful, yeah, to see that one by one, and you're starting to get this picture of the different categories. But if you go to the next slide, and this is the hectic one that I'll actually go and click again. That one's about healthcare providers, same idea. This is where on the left, if you click again, you'll just see that the circling vaccinated, and click again. The next group is intending again. The next one is the undecided group, and then the bottom one is those who are not intending to be vaccinated. And click one more time. This is when you put together all of those items that relate to the thinking and feeling from the model, the same items that were just on the previous slides. But if you put them together, and actually statistically, you can run factor analysis and regression, and the numbers will come out quite clearly for you. But you're starting to get a very full picture, and you can actually see different people in this. And of course, in behavioural terms, we call those personas. So using the data to create personas is what we've been trying to do in the region, so that we could more specifically respond. Now, we didn't only use this data, we also used a range of other data like social media data. And we could also look at different age groups, we could look at gender issues, etc., on top of all of this. So it's still a complex task, but again, statistically, we could run this rather than just sort of eyeballing it like this. And it makes a very big difference. You see, for what we found, for example, is that women of reproductive age, which is quite a large group of women in our region, they were concerned about certain side effects, and that was related to the misinformation around, it was actually misinformation about fertility. So we were able to, and some countries like Sudan and others, design specific programmatic interventions to address that, and we're able to see quite substantial changes in vaccination uptake. So next slide. So just to reinforce, then, this idea of that, yes, the movable middle, but if you click again, it's important to, click again, It's important to then break it down, oh, sorry, not that many times, back one. So just making the point that there are people on this continuum, and they have very specific views, and there are very specific barriers that are affecting how quickly or whether or not they're being vaccinated. Next. So also wanted to say something about this matrix, which you also saw Lisa provided. So we use this to identify what are the key issues for in terms of the different constructs. We try to then identify what sort of behavioural insights or what sort of effective interventions could we apply, etc. Now, just one thing, what we found in our region is, on the left there you have the thinking, feeling, the social networks, and down the bottom there in the orange, what in the model is called practical. We tended to refer to that as systems level and structural level or environmental factors, because we found that people were more easily able to program more specifically for those issues, and they were the same things that you saw in the model that's been presented. Things like access, is the clinic open at the right time? Are you able to access it, etc. So in the interest of time, I might just skip through this next section on social norms, because I think it will come up in the final, in the discussion. But just to say, if you click through, there's a couple of slides here. You just click again, and click again. Yeah, okay. So Yeah, we're just on this slide here. So what we were also able to say and to use social norms, just back one. Yeah, just click back one to the social norms slide. The point I wanted to make anyway is that we were also able to say that a majority of the population is thinking, feeling, doing certain things. And again, this is an example of framing, but it does influence, and because, as this UNICEF resource suggests, everyone wants to belong, and that's the definition of the social, well, almost definition of social norms as well, where you have people, once people think that others in their community or others like them are thinking, feeling, doing certain things, you are actually more likely to do that yourself. So by looking at the data, we also were using social norms in terms of our program interventions. So next slide. And just on in terms of tips, four quick tips. Next, click. So the first one is about the use of the theoretical models to guide decisions. It not only helps you identify what the constructs are and then the standardized items from the work that Noel and others have done, helps you choose which ones, but it also helps you to say no to certain things. I'm sure many of you have been involved in developing surveys, and they usually get much, much bigger before they get smaller. And this is using theoretical models is a way to identify what will be the most useful items to include, and hence the priority items that have been discussed already. The other thing about the models is that they do have individual factors, and that's the knowledge factors, for example, and attitudinal, motivational factors as well, psychological factors like whether you intend to do things or not, your beliefs, etc. And these are all important, but the structural factors and the systems factors are usually the most powerful about the experience of the clinic, whether people can access them, these sorts of things are the most powerful. I mentioned also the second point just about descriptive versus behavioural analysis using psychometrics or psychodemographics rather than just descriptive, just describing one by one. The use of personas has been particularly useful to us for designing interventions, and this idea of social norms, using them to frame our interventions and some of the information. Next, click. The third point is about the movable middle, focusing on the area that is amenable to change and the subgroups that are amenable to change, but also looking at those, making sure that you have multiple responses. It's not just a single response. And just lastly, just the last point is having done this, randomized sample of, a behavioural survey. Just click again. You would think that I'm going to recommend that, we should all be doing this. I think it's very important to have randomized data and a clear sampling frame because it does give you a clear denominator. However, in outbreaks, pandemics, epidemics that are moving very quickly, it can be too slow. So by the time you collect this perfect data set, analyze it, feed it back, turn it into personas, etc., your pandemic has moved on from you. So it's very important to turn that around quite quickly. It's very, very useful data. And we certainly got better at turning it around quickly as well within weeks, as opposed to the first one took a little longer. But I think it is very important that we think about innovative methods, and I think we are sort of more accepting now of some of the weaknesses, say, of things like social media. But it's still useful when we look at it in a triangulated kind of way. So I'll just stop there. You can click, and I think you'll see some resources there on that slide that I hope will be useful to everyone. Thank you.
Thank you very much. Thanks, Amaya. Thanks, Noel. Thanks, Lisa. Thanks to all three presenters. These were really great presentations. I see some questions and comments in the chat box, and I'm going to go with the order that they were posted there. Let's start with the first question on whether there's data in Europe on vaccine intentions. And maybe I can add to that question a little bit, broaden it a little bit, especially when it comes to vaccinations of children. Do we have hotspots? Where are the problems? Which countries or which regions should we focus on? Lisa,
Thank you.
For you.
Yeah, sure. Thank you very much. A really good question. And so thinking specifically about childhood vaccination and in the European region, and firstly, just considering coverage, this is quite variable across the European region. And really, I'm not the best person to speak for this. My European colleagues would be able to give you examples of countries where there are hotspots, or even regions or districts within countries where there's particularly low uptake. So it is quite variable. But as for the reasons for low uptake in different European countries, this is also quite different depending on context. My colleagues have, over the last couple of years, gathered data through surveys to better understand reasons for low uptake. The approach that they've taken has been to also ensure that there's qualitative data gathered through in-depth interviews to really have a richer, deeper understanding. And they're considering this behavioural insights research, and they have used this in a number of Eastern European countries and countries in the stands, and that has offered to them really useful insights for planning purposes. I'm not really in a position to speak in general terms about what those barriers are. One thing that has stood out when they've spoken about these findings is that they have found that the practical barriers, the access-related barriers, have often been much more dominant than they would have anticipated. And I recall that they've offered examples of countries where they might have anticipated a lot of hesitancy, low confidence, or even mistrust in vaccination for various reasons. But often they've also found that there are practical or access related barriers that are also getting in the way. This is perhaps a little anecdotal, but a recurring theme in the data that they have found. And I think it potentially also speaks to possibly a lack of investment in some of these countries in quality services, and services that really meet the needs of those communities and meet them where they're at in terms of needing to really ensure that vaccines are available, affordable, at different days, different times of days, and with well-trained health workers as well. So just speaking generally, but those are some of the main themes that have stood out from the data that they have gathered.
I'll add two observations. The first is that we should distinguish between observational data, what we can sort of measure when we talk to people, and then what happens as a result of interventions based on those observations. So in terms of observations, when you ask people why they don't get a vaccine, you usually get a broad range of answers. It's very rare that there's a single one thing. So there's 5 or 10 or 15 things that represent the entire population. That's my first point. The second point is that the original work on the BeSD model, the BeSD framework, is based on something called the increasing vaccination model that I developed. And that model was designed specifically for intervention, to summarize what we know about interventions. And picking up on a comment that Amaya made, the interventions that are most effective are all in that blue box, that all deal with practical issues, that deal with automatic scheduling of appointments. Those are effective. That deal with reminder recall, that deal with requiring vaccines, providing it free, providing it on site in schools and workplaces and care facilities. All of those things are reliably effective in ways that some of the other things, that show up as being highly correlated with behavior like confidence are not always reliable intervention points. So when you're thinking about understanding what's going on, it's important to have confidence in the system and high trust. There's no question about that. But perhaps one of the most important aspects of that high trust is it allows you to do all of the stuff in that blue box that is highly effective. So in order to have programs and campaigns that really change vaccination, the populace, as well as political leaders, have to believe in vaccination.
Thank you very much, Lisa and Noel. There was a question early on whether we can compare this, the level of intention, with the diffusional innovation theory, DIT. I wonder if you're familiar with this theory.
Yeah, I'll jump in. Actually, yes, I think that this is exactly what I meant by saying that, you know, the beauty of this framework that we're using is that it's simplified, and it does include a lot of thinking about various other models and theories, behavioral theories. And so it's included, you don't have to do the thinking, you know, sort of. But diffusion of innovation is a very interesting one to use, or sometimes it comes from the stages of change work as well. And this, for people who are not familiar with it, it's about the fact that people are at different stages of change for any behavior. So if you think about maybe the slides, if you recall the slide that I had with the different people on it, sitting along that continuum, that put those personas, if you like, the people at the far edge of the red, they're at a very early stage, and in fact aren't even thinking about changing. They're not even thinking about getting a vaccination. They're saying they don't want one, even if you offer it to them. Whereas the people at the other end have already had their first vaccination, you know, and some of them are advocating for vaccination for others, and, you know, highly motivated. So, and in between, you have additional stages. The full model, the full theory provides that to you. So the idea that you can sort of nudge people along a continuum, it is a useful way to think about that. There are other aspects to diffusion of innovation theory and other ways to think about it as well. The idea of laggards, you know, some people are early adopters, some people are slower to adopt. But I think this is all the same sort of neighborhood of thinking around that different people are at different stages in the same behavior, and they can live in the same community. There does tend to be some homogeneity, like people tend to be similar in a community, but you do still see variation, and there's always a need, particularly for, you know, national government planning. Definitely there's a need to look at what are the segments of the population, and this is where this data can help you do that.
Yeah, and the general area that we're in is something called motivational framing. There's a large meta-analysis that just came out in Psychological Bulletin that identifies the effect size as 0.20, an R of 0.20, which is pretty big for somewhat small intervention. So the idea here is in practical terms, you have to decide, do you have one ad or do you have 4 ads? Do you have one campaign or do you have 4 campaigns? And it turns out that if you're going to create these different campaigns, the most important thing is to focus on their intention, their motivation to act. If you focus on only one thing and distinguishing among your campaigns, that's the thing. And that's exactly what Amaya was talking about and was doing. And so you can think about having 4 campaigns, or alternately one campaign that addresses your 4 kinds of people, so that each of those people can see themselves in the ads or in the campaign and get what they need from it. And that will just depend on your budget and what's realistic and your time frame.
Thanks, Amaya and Noel. A few questions, very practical in terms of collecting this data. First, a question about whether you have had a chance to compare data collected face-to-face and over the phone. How would they compare? And let me read the other questions too, which come more or less in the same context. Could these questions be customized to ask any adult household member, as opposed to we are referring to those questions on children under 5, as opposed to those to asking these questions to parents and caregivers? How would they perform? And thirdly, given that attitude, and of course, this is not about the pandemic, but a more established hesitancy situation or low uptake, what would be the appropriate frequency for data collection on these issues when we know that attitudes are not going to be changing very fast? What would you recommend in those cases? Frequency of data collection.
Well, that's a lot.
Yes.
All right, I can say something brief about the mode. The answer is we probably don't really know. There doesn't seem to be a huge difference across them. I wouldn't be too concerned about mode differences here, and mode being like, do you do it by telephone, or do you do it in person, or do you do it online? There are differences. I think what's even more important, if you want to look at comparability, is just ensuring that all the response options are the same, that the wording is the same, and that you've done the work to ensure that these items are seen similarly across different languages. There can be some really important differences across languages that can account for a lot of these differences. How do you adapt for other people? These items are pretty robust. I don't have a lot of concerns about them. I would be more concerned about asking questions among people who don't really know. So at least in the US, some 80% of vaccination is handled by the mom. And so the asking dads about this is going to get you a lot less useful information because they're not generally the decision maker. But there can be other places where it's shared, or it might be that the mom is taking the kid to the clinic, and then but there's another figure in the household who is the main decider, and so that's a place where you'd have to take that into account. And then in terms of frequency, that's going to be up to you. I've participated in work with the CDC where we did this every month, and so we tried to create monthly measures. And I'm not sure that we saw a lot of useful data at the frequency of 1 month. I would say every 6 months to a year is pretty ideal. But if you're dealing with a crisis situation where there's a safety signal, an unfounded safety scare that you're trying to manage, that's a place when moving to monthly data might be really helpful.
Mm-mm. And just to also complement, adding on to the question about the frequency of data collection. So absolutely, we spent a lot of time discussing this, taking into consideration different country contexts and needs as well. So a country that has high coverage of childhood vaccination might be able to carry out a national survey much less frequently, maybe only every, say, 2 or 3 years, but then use qualitative data collection, the in-depth interview guides, to really pinpoint specific districts or communities or populations where there's a real need for more granular, in-depth data to inform a better understanding of the reasons for low uptake and related interventions. So it will vary depending on the country, their overall coverage for, say, childhood vaccination or the vaccine in question, the extent to which that's generalized across the entire country or specific hotspots, and then the ability to use a mix of the survey or the priority indicator questions or the qualitative tools. So this is going to generally be quite context specific. But as a rule of thumb, we did come up with a recommendation that for countries with overall low coverage, that they may consider a survey nationally every 2 years, just to start to establish a real comprehensive understanding of these reasons and to be able to track trends as there are targeted interventions that are implemented over time. Thanks for those good questions.
Thank you so much. Amaya, I see that you have been answering some of the questions in the chat box, but here's another question for you. What are you able to say about people which were not covered by the MENA phone surveys? Those people without a phone. Any bias that you would think of the segment that would introduce to the results?
Yes, definitely. All approaches have strengths, weaknesses, as I put into the chat there. You know, whatever you do, there's going to be a strength, there's a trade-off, you know, strength and a weakness. We know with phone-based surveys, the biggest difference, of course, phone-based versus face-to-face is the cost. and the time, and of course these two are linked. It's much more expensive. For sensitive topics, phone can be better, or tablet-based can be better than face-to-face. COVID wasn't particularly sensitive, so we don't think we got that sort of bias, and we did look into it in the testing phases. But we do know that phone-based surveys in our region are biased against women, because women tend to have less phone ownership and less phone access. But knowing that, and then as long as that's consistent over for us over the 3 time points where we collected data, then you can make some sense of the data, and we have no reason to believe that it changed over that time. But yes, I mean, and that's why I also made the points about social media, because all of the countries in our region had access to some kind of social media monitoring, which is real time, it's 24/7, it's fantastic, it's right there, it's basically free. Although if you pay, you get a better version of it and more analysis. This is really great stuff, but you have no idea what the denominator is many times. You can get a glimpse of what your bias is. So the idea of triangulating that, or if you have a randomized sample and you have a denominator that you can compare against, then you're able to make a bit more sense of some of these things. So I think the trade-off there is time, so the access to social media monitoring is rapid and real time, and it's terrific in a pandemic, but it doesn't give you the full picture. It gives you a biased picture. But you don't have time to do randomized controlled trials for interventions, or even just for the basic data collection. So it's these trade-offs, and we definitely had a mix of these things happening. We did these the randomized samples over 3 points in time over a year, and individual countries did additional national and subnational surveys like that were randomized. But we layered on top of that social media monitoring, qualitative, as well as a whole range of sort of in-betweens. Yeah. So I think the idea of bias is always a question that you ask, and you want to look deeply at it, but it's not one you can completely remove. Over.
I'll add 2 comments. One is that the idea of bias is important when you're establishing point estimates. What percentage of your country's population is vaccinated? That's really important. And maybe if you want to say what percent are confident in vaccination. Now, if you're starting to look at associations, that bias drifts away. That there's no evidence that I've seen that associations are biased, even in biased samples. We actually have some pretty powerful data showing quite the opposite, that the pattern of findings in these biased samples and unbiased samples is roughly identical. So when you're looking at point estimates, it's one thing, but when you're looking at associations, it's another. The second point that I'll make is that if you're looking at disparities work, you're trying to identify populations where there's unmet need or where disparities are present, it is very important to have representative samples. And that's a place where that extra 20% response rate or even 10% can cause disparities to appear in data that are otherwise invisible. A really important empirical finding that's been shown repeatedly.
Yeah, thanks. Very good points from both Amaya and Noel. Amaya, after I asked the question, I saw that you had actually commented on it in the chat box, but it was good to give you another chance to expand more on it. But still, to continue with the work in Monaro, you had really great findings, and this was a great survey on the phone. What has there been any action taken based on these results at the regional level or at country level? What happened afterwards?
Yes, well, most of the sort of interpretation and the lessons learned that I was talking about there was about how we had utilized the data. So we were collecting the data regionally, but as I said, the individual countries also had their own national data sets and additional data on top of that. So the things that I mentioned are exactly what we were doing with it. It changed the way that we framed our interventions. It made clear the need to move away from campaigns and knowledge-based messaging, just messages. But not that, there's certainly information and clarifying misinformation was important, but it put a real nuance on how we looked at that, and really made us look much more broadly at a full range of interventions well beyond information, looking much more at social influence, for example, who is able to influence, and a couple of people talked about the importance of religious leaders, for example, but also women, young people. You know, there's a whole range of influencers and influencers in this. So the data allowed us to look at that. I didn't show all of the items in the survey, but we did ask about, you know, there was interesting findings around where do you get your information versus do you trust it? And everyone uses social media, but not everybody trusts it. And people who are more open to vaccination tend to trust social media less, for example. Similarly, so it changed the channels that we use. So countries were looking at, and they could actually look at subpopulations and the use of their, you know, what are their preferred channels, and which channels they trust more or less as well. Another interesting finding was that health workers, when we asked who do you trust in terms of, you know, not just channels, but health experts, religious leaders, celebrities, you know, what we found was everyone, in terms of those 4 vaccination categories, everybody trusts health workers. Now, people who are positive to vaccination trust them more, but even people who are resistant to vaccination, COVID vaccination, health workers were the most trusted source of information. So this is useful. You know, it means that, you know, we do have an angle there, and we did additional work to show how you could use, you know, religious leaders with a health expert was actually the most effective way to, you know, in terms of the messenger, if you like. So there's an enormous number of ways that we were able to use that data to create that nuance. But the really important, I think the big picture ways was this use of personas, the idea of the fact that you might need more than one type of intervention, so that it isn't just a set of messages. I think that was really, you know, the really big picture shift that we made. But there was, you know, multiple ways that different countries use it. Use the data in each case and continue to do so. I think the COVID-19 experience actually helped many countries understand behavioural data and are now applying that to a whole range of other sectors and areas now. And I know there's a question there to Attila about the spillover of COVID-19 attitudes into childhood vaccines, so that's also perhaps an area that we can get into as well. Over.
There is one thing I'd like us to touch on briefly in terms of the practical use of these tools. I'd like to hear from Lisa, if possible, about the plans that you have for helping countries take the data they collected and quickly analyze it in some kind of a dashboard approach. That's one thing. And the second, Amaya, maybe a very brief comment from you on what you did to speed the sort of more sophisticated analysis, like instead of just using a dashboard approach, which is what Lisa's going to talk about, how you what were the 2 or 3 things you did to just speed up from getting data to being able to use it?
Thanks, Noel. And just quickly responding on this. So to say that we are in the process of finalising and just about to disseminate some tools that will exactly collapse this process from collection of data using digital tools through to rapid analysis and reporting using pre-developed templates, and then using these reporting reports basically to inform local planning and matching some of those findings with initial recommendations for evidence-based interventions that are shown to act on those various barriers like we've discussed. So absolutely stay tuned, and we can share back with this network the forthcoming tools to assist with rapid analysis and reporting. And the other thing is, with partners, we are going to be gathering and analysing available data that's gathered using the BeSD tools. And part of that will stream through the WHO UNICEF joint reporting form that's being completed right now by countries and member states to WHO and UNICEF. And we will be consolidating and analysing all of this available data for childhood and COVID vaccines and making that available through a global dashboard later this year. So that's also something to keep an eye out for. And we will be regularly updating that dashboard as well at future time points as more and more data becomes available in this space. And there will be more cross-partner work happening as well to keep this entire community well informed on iterations to the tools, these added supplementary resources and the findings. So I can add that as well. Thanks.
You. Amaya, did you want to say anything?
Well, just quickly, in terms of the question Noel posed about how did we speed things up, basically it was practice. One of the things I think that is really important for all countries is to actually increase their capacity to do behavioural analysis and behavioural science in general, to have that local capacity, because it hasn't been in place. So I think that is a real issue. Having an analysis plan, we had one for the first time point, but the first time you run a survey is when it's just so labour intensive to actually get a sense of what is going to work, and to run the factor analysis, and even running regressions, etc., and even tweaking certain questions, because the pandemic and outbreaks also change as well. So we had to change slightly each of the survey tools as well, because we were getting vaccines were more available, or different vaccines, or there were slight differences happening, or the public health and social measures, for example, were changing. So it was basically practice, where we knew when the second one came around, we knew what was coming, and we sort of had templates for each of the countries. But I'm not sure we are really fast enough, not on that first data collection. That is what it really needs specific capacity and expertise in this area. Over.
Thanks, Amaya. Thanks indeed to all three presenters, Lisa, Amaya, Noel. This has been a great webinar. I hand over to Archana now to wrap up, and we close the session. Thank you very much.
Thank you, Attila, Amaya, Noel, and Lisa, with the great presentation. Thank you for all the participants for their great questions and comments. I just want to remind everybody that the next webinar will take place on May 3rd, 2 Wednesdays, and it's going to be from now, and it's going to be very exciting because we will be going live to Amman for an actual mix workshop. And the topic would be on the Mix 7 questionnaire, architecture and content. So definitely don't miss that. And just a reminder that these will be available on the UNICEF SharePoint site, both the presentation as well as the recording, and it will also be available on the Mix YouTube channel for our external colleagues. So with that, I wish everybody a very happy day, evening, or night. All right. See you next time. Bye-bye, everybody. Thank you.